Last week I gave you 6 numbers: fasting insulin, triglyceride to HDL ratio, high sensitivity C-reactive protein, HbA1c, uric acid, HOMA-IR. And I told you that Sandra, 56 years old, 8 years of clean annual panels, had all 6 of them outside the optimal range simultaneously. And that in 6 months, following the protocols we covered in the first 3 videos, every single one had moved into or toward the optimal range. Today I want to do something different. I want to take you inside each number. Not just what it is, but what is actually happening in your body that makes it high, what the mechanism is, and what that mechanism tells you about which intervention will move it. Because here's the thing I have learned after years of practice. Patients who understand why their fasting insulin is high are dramatically more likely to do the things that bring it down than patients who simply receive a printout and a recommendation. Understanding is the most powerful compliance tool that exists. I'm Dr. Zhang, and I want to start with James. James was 48 years old when he came to see me. He was a project manager, high-functioning, high-stress, perpetually busy. He had come to me not because he felt sick, but because his father had developed type 2 diabetes at 52 and his older brother at 49. He wanted to know if he was on the same trajectory. I ordered the standard panel and the 6 additional tests. His standard panel was unremarkable, within reference ranges across the board. His 6 metabolic markers told a different story. Fasting insulin of 14.2, triglyceride to HDL ratio of 3.1, HSCRP of 2.4, HbA1c of 5.6%, uric acid of 6.2, HOMA-IR of 3.3. None of these values were catastrophic, but every single one was outside the optimal range I described last week. And the pattern, all 6 elevated together, was the specific metabolic fingerprint of early insulin resistance driven by chronically elevated carbohydrate intake and insufficient metabolic flexibility. I showed James the results. He looked at them and said, "Which one do I fix first?" That is exactly the right question. And the answer is not obvious, because fixing the wrong one first, or trying to fix all of them simultaneously, produces slower results than fixing them in the right sequence. Today I'm going to show you the sequence, but first I want to take you inside each number so you understand what you are actually fixing. Let's start with fasting insulin, because this is the master signal. Everything else downstream. When fasting insulin is elevated, it tells you one thing with remarkable clarity. Your cells are not responding normally to insulin. The pancreas is producing more insulin than it should need to, because the cells it is trying to communicate with have become less sensitive to its signal. This is insulin resistance. And the primary driver of insulin resistance in the majority of adults over 40 in the developed world is the same thing: chronic carbohydrate excess producing chronic hyperglycemia, producing chronic hyperinsulinemia, producing progressive receptor downregulation. Here is the metabolic sequence in plain language. You eat refined carbohydrates. Blood glucose rises sharply. The pancreas releases insulin to move that glucose into cells. Cells respond, glucose clears. But if this pattern repeats many times per day, every day, for years, cells begin to downregulate their insulin receptors. They have been stimulated so often and so intensely that they reduce their sensitivity as a protective mechanism. The pancreas responds by producing more insulin. Fasting insulin rises. The elevated fasting insulin now suppresses fat oxidation continuously because one of insulin's primary functions is to signal the body to store energy, not burn it. Visceral fat accumulates, liver fat accumulates, and the cycle that we described in video number 1 accelerates. What brings fasting insulin down? The answer is anything that reduces chronic insulin stimulation. Time-restricted eating, because it creates extended periods of low insulin that allow receptor sensitivity to recover. Reducing refined carbohydrates and fructose, because these are the highest insulin-stimulating macronutrients. Zone 2 aerobic exercise, because it improves cellular insulin sensitivity through a mechanism called GLUT4 translocation, which we will discuss in the protocol video. And reduction of visceral fat itself, because visceral fat produces inflammatory signals that directly impair insulin receptor function. Notice that all of these are interventions we have already discussed. Fasting insulin is the number that tells you whether those interventions are working. It is the master feedback signal for the entire metabolic system. Now let's look at the triglyceride to HDL ratio, because this is where the story of insulin resistance shows up in your circulation. When insulin is chronically elevated, it activates a liver enzyme called DGAT that increases the assembly of triglyceride-rich VLDL particles for export into the bloodstream. Circulating triglycerides rise. Simultaneously, elevated insulin suppresses the production of ApoA1, the protein that forms HDL particles. HDL falls. The ratio widens. A triglyceride to HDL ratio above 3.5 is therefore not primarily a cholesterol problem. It is an insulin problem visible in the lipid panel. This is why the low-fat dietary era was so metabolically destructive. Replacing dietary fat with refined carbohydrates elevated insulin chronically, which drove up triglycerides and drove down HDL simultaneously, producing the exact pattern of atherogenic dyslipidemia that the low-fat guidelines were supposed to prevent. The guidelines moved LDL numbers favorably in many people. They made the triglyceride to HDL ratio worse in the majority. What brings the ratio down? Reducing refined carbohydrates and fructose, the primary insulin stimulants. Omega-3 supplementation, EPA and DHA directly reduce triglyceride synthesis in the liver. And visceral fat reduction, which reduces the portal delivery of free fatty acids to the liver that drives triglyceride assembly. James's ratio of 3.1 told me his liver was processing too much carbohydrate-driven triglyceride load. His fasting insulin confirmed why. Now let's look at hsCRP, the inflammation signal. High-sensitivity CRP is produced by the liver in response to inflammatory cytokines, specifically interleukin-6 and tumor necrosis factor alpha. We discussed these cytokines in video number 1 in the context of visceral fat. They are the inflammatory signaling molecules released by macrophages infiltrating expanding visceral fat tissue. Elevated hsCRP is therefore, in most adults over 40 without active infection or autoimmune disease, a downstream readout of visceral fat-driven chronic inflammation. What brings hsCRP down? Visceral fat reduction, which reduces the source of IL-6 and TNF-alpha. Omega-3 supplementation. EPA and DHA compete with arachidonic acid in the inflammatory cascade and reduce CRP production. Extra virgin olive oil. Oleocanthal inhibits the same COX enzymes that produce inflammatory prostaglandins. Time-restricted eating, which reduces the late-night portal fructose delivery that drives hepatic inflammation. Every one of these is an intervention we have already discussed. James's hsCRP of 2.4 told me he was in moderate cardiovascular risk territory, not from a vascular problem, but from visceral fat-driven inflammation that would eventually become a vascular problem if left unaddressed. Now, HbA1c, the 3-month glucose picture. HbA1c rises when blood glucose is chronically elevated. It falls when blood glucose normalizes. The key insight for metabolic health is that HbA1c lags behind the other markers. It takes 3 months to reflect changes in glucose management. This means it is a lagging indicator. When you implement the protocol and your fasting insulin begins falling within 4 to 6 weeks, your HbA1c won't reflect that change until the 3-month blood draw. Do not use HbA1c as your primary short-term feedback signal. Use fasting insulin and the triglyceride to HDL ratio for early feedback. Use HbA1c to confirm the trajectory at 3 months. James's HbA1c of 5.6% was in the top quarter of the officially normal range, close to the prediabetes threshold, and consistent with the early insulin resistance his other markers were showing. Now, uric acid, the fructose signal. We covered the mechanism in video number 2 and again last week. Uric acid is a direct metabolic byproduct of hepatic fructose processing. When fructose floods the liver through the unregulated GLUT5 pathway, ATP is rapidly consumed in the phosphorylation step, producing AMP, which is then degraded to uric acid. High uric acid is therefore a sensitive early signal that the liver is receiving more fructose than it can efficiently process, a signal that predates the development of elevated triglycerides and elevated fasting insulin in the metabolic cascade. In practice, this means, if your uric acid is elevated and your other markers are still within range, you may be at the earliest detectable stage of the metabolic dysfunction cascade. This is the best time to intervene. What brings uric acid down? Removing liquid fructose from the morning fasted state, the most damaging delivery pattern we discussed in video number 2. reducing total fructose from juice, honey, sweetened beverages, and dried fruit. Adequate hydration, which supports renal uric acid clearance. And cherry consumption, a finding from multiple small clinical trials showing that tart cherry consumption significantly reduces serum uric acid through a mechanism involving xanthine oxidase inhibition. James's uric acid of 6.2 confirmed what his dietary history suggested. He was consuming significant liquid fructose, a morning smoothie with banana and mango juice, which he had considered a healthy breakfast. He was wrong. And finally, HOMA-IR, the calculated summary. HOMA-IR integrates fasting insulin and fasting glucose into a single composite index of insulin resistance. It rises as insulin resistance worsens and falls as insulin sensitivity improves. It is the most direct, calculable measure of where your metabolism sits on the spectrum from optimal sensitivity to severe resistance. James's HOMA-IR of 3.3 placed him in the clinically significant insulin resistance category. Not yet diabetic, but on the trajectory his father and brother had followed. Without intervention, his trajectory was clear. With intervention, it was equally clear, because we now have the evidence from multiple randomized controlled trials that every one of the markers I have described today responds to the same core protocol. James asked me, "Which one do I fix first?" Here is what I told him. You don't fix them one at a time. They are all downstream expressions of the same upstream dysfunction. Chronic insulin stimulation from refined carbohydrate and fructose excess, driving visceral fat accumulation, driving hepatic inflammation, driving all 6 markers simultaneously. You address the upstream driver and all 6 move together. The upstream driver is the morning fasted fructose delivery, the smoothie. It is the chronic refined carbohydrate load through the day. It is the absence of a defined eating window that keeps insulin elevated for 16 hours a day. Address those things, and the system self-corrects. I told James to do 3 things. Remove the morning smoothie, implement an 8-hour eating window, add 30 minutes of zone 2 walking before his first meal. Nothing else for the first 4 weeks. At 4 weeks, fasting insulin down from 14.2 to 9.8, triglyceride to HDL ratio down from 3.1 to 2.4, uric acid down from 6.2 to 5.4. At 12 weeks, the first HbA1c retest window, fasting insulin 7.6 in the optimal range, HbA1c 5.3% out of the elevated risk zone, HSCRP 1.4, HOMA-IR 1.7 in the normal range, triglyceride to HDL ratio 2.1. James had not been diagnosed with anything. He had not been prescribed anything. He had removed a smoothie, added an eating window, and added a morning walk. His father developed diabetes at 52. James is 49 now. His current metabolic trajectory is not his father's. That is what these 6 numbers can do when you read them correctly and act on them in time. In my next video, I'm going to show you the person who came to me not at the early warning stage, but after a confirmed NAFLD diagnosis, and who reversed every marker, including hepatic fat measured by MRI, in 90 days. I'm going to show you her exact protocol in the exact sequence she followed it, and the specific blood work timeline so you can see precisely when each marker moved and why. If this video helped you understand your own numbers, please share it with someone who has been handed a blood test printout and told it was fine without any explanation of what the numbers actually mean. That happens every day in every clinic. It doesn't have to. Subscribe to Dr. Zhang Health. I'm Dr. Zhang. Understanding comes first. Everything else follows.